TopMedTalk.
Well, welcome to TopMedTalk. We are here in Chicago at the Society of Cardiovascular Anesthesiologists 41st annual meeting. I'm Desiree Chappell, host and managing editor of TopMedTalk, and I'm joined by Saul Aronson, my co-host and past president of the SCA. Hello, Saul. How are you?
Pleasure to be here. And everybody keeps bringing that up.
I know. Well,
years ago.
Saul, you have a ribbon on your badge. I'm sorry, I just cannot help myself.
Right.
Well,
proud past
That's
president.
right. Proud. You should say
right.
that.
Right.
So we had the opportunity to catch up with a friend at the TopMedTalk family, Dr. David Ramisingh. Hi, David. How are you?
I'm very good. Thanks so much for the opportunity. Glad to catch you guys on the last
I
day.
know. I was like, hey, come on over, Snaggy again. But glad we could catch up because I know there's a lot of things that we've actually talked to you on TopMedTalk twice now, or three times maybe.
3 times,
3 times about several different topics that hopefully we can talk about and chat today. A couple of those being the POCUS efforts that you're doing, point of care ultrasound stuff, which I think is absolutely amazing. Love everything that you're doing in that space. And then enhanced recovery for cardiac surgery, and really with a focus on goal-directed therapy. Right? Yeah. So before we get into that, I do want to make sure that we know. So you're from Loma, right, in California, and your title there is?
So I'm Director of Clinical Research and Perioperative Ultrasound.
Okay.
And I'm part of the cardiac anesthesia team there. So a lot of my efforts are focused on both those areas, on improving clinical research opportunities, evaluating the implementation of quality improvement projects like the Cardiac Enhanced Surgical Recovery Program that we launched, and on the topic of perioperative ultrasound, really trying to educate and increase the awareness on that topic and prove its clinical utility for perioperative providers.
And you launched the Enhanced Cardiac Enhancement project when?
So it officially launched after all these efforts, 2 years in the making,
right.
But officially launched in January of this year, where and really it's a multidisciplinary effort to create a rather very straightforward protocol. What we do is we identify using the concept of optimizing both flow and pressure, right? So we identify targets post-bypass. Those targets are identified per patient specifically, and then those targets get met into the ICU for the first 12 hours of their ICU admission. And so they have the opportunity to re-engage and adjust their target parameters, but it's really a patient-specific target parameter protocol.
David, talk to me a little bit about how those target-specific metrics, parameters are established.
Okay, but first we're talking about just enhanced recovery, so we're not the continuum of care in the broad scale of that, but you're talking about specifically with fluids.
Correct. Well, with hemodynamic management.
Hemodynamic management is a better way to put it.
Fluids, inotropes, vasoconstrictors, but focus just on hemodynamic optimization, post-bypass into the first 12 hours into the ICU.
Okay, so do you had an enhanced recovery program in general for cardiac?
Not for cardiac. So we've launched many enhanced surgical recovery programs for non-cardiac surgery, variant vascular surgery, colorectal. But for cardiac, it's always an interesting topic. I always enjoy talking with Monty on this, on the idea of it's something. It's a unique space, right?
Yeah.
People think that we're always doing the right thing for hemodynamic optimization when it comes to cardiac surgery, but it's not protocolized. It's more of a challenge to get that in a protocolized fashion. And
so that's what you're talking about.
That's
is
what
just
we're
the
talking about.
protocol for that. Great.
And fundamentally, the idea was that, at least in our group, one of the main barriers we had was nobody liked the idea of identifying targets of certain parameters, of saying an index of 2.5 or 2.1 or 2.2, and then that being the cutoff value to make your decisions, because we know that cardiac patients are dynamic, right? Their pathologies, how they come and present to you, one given patient may be very different, and those are not realistic targets perhaps for that patient. And so that's why I think if there's a unique component of this protocol is just that we identify a patient-specific target post-bypass, and you're going to ask about
that. And so now I'm going to re-inject my question, which is teach us how you come to those parameters.
Right,
what is your trigger to decide that is what your target, if you will, parameter is?
Yeah, so it's a combination, right? So we identify it, and I'll kind of just walk through the idea of how we work on this. post-bypass, once the period of time where the patient is separated from bypass and we feel that the patient has received all reversal for protamine and they feel like their hemodynamic stability from a blood pressure side of things has become stable for about a 10-minute period. So sometime within the first 45 minutes of separation of bypass, we then look at the echocardiogram. We look at, again, the blood pressure. We look at the surgical field. We discuss with the surgeons about if they have any concerns or if they're getting nearer to the point where they'll start to consider closure. We look at what their bleeding status is and feel we're comfortable with that. Assuming those two are met, we then, again, reconfirm with the echocardiogram about what we see about the function and the volume status. And then we look actually at our hemodynamic monitor and see what values that monitor is giving it to us for a 5-minute period of time. And that's how we identify the targets. And from that target standpoint, we then adjust the remainder of the patient's intraoperative period to opt to maintain those within a 10 to 15% threshold. And once they go into the ICU, same idea, where they follow a 15% threshold marker of change in either blood pressure or cardiac index.
Interesting. So if I may,
yes.
I'm going to reframe what I think I just heard you say because it's fascinating. So what I heard you say is that you're using the echocardiogram and conversation with the surgical team
Correct.
To confirm that you met the expectation of the surgical repair itself.
Exactly.
And that be validated and codified, if you will, by the echo. And you use the echo almost as a gold standard to judge function, flow, volume.
Correct.
And then you correlate those findings of what is met expectations and observations of hemodynamics on the echo
Correct.
to the hemodynamic monitors that are non-echo related.
Yes.
And then use that as your post-operative guide.
Correct.
Based on the association. Excellent. Got it.
That's exactly it. I mean, thank you for
reframing.
Yeah, exactly.
So how's that going?
Well, it's going well. I think, again, the 2 years in the making. I think the reason why it is going well because we did do a multidisciplinary effort to try to get this protocol developed, meaning that nobody, as I mentioned, nobody was very excited about the idea of coming up with set standards. We actually tried to say, let's develop a protocol that has what targets should we have, a mean arterial blood pressure for all our patients above this level, a cardiac index above this level, and then we'll decide adjustments of fluids, inotropes, and vasoconstrictors. That met so many roadblocks because when you involve the intensivists, the cardiac surgeons, and the cardiac anesthesiologists, we all had different opinions. And it was becoming we weren't getting anywhere with it. And so once we kind of talked more about the communication efforts, as you so well described, I actually probably will download this podcast just to learn how to re-summarize that. But exactly like that, to help with that communication to see, okay, now that we're just communicating about what the targets are, just a simple thing about we weren't even really, honestly speaking, doing a great job of identifying a target mean arterial blood pressure. Yeah. Kind of behind the drapes, we were doing what we thought was appropriate. The surgeons would occasionally look and have a discussion, but we never really just flat out said, this should be the target for this patient. Right. And simple things like that, I think putting in a protocol, identifying that, and that, again, it's all, we actually, very simply, it goes into our EMR, but we have a paper sheet that we just literally stick to the monitor, both in the OR and into the ICU, and the nursing team knows to look at this piece of paper to see what targets they are, and just use that as the avenue of communication.
It's really interesting. I'll just reflect back on my own anecdotal experiences and reflect on how many times we have done essentially what you are saying, but you so nicely framed it in a protocolized manner. But we often see, that there's a regional wall motion abnormality that is more pronounced when your blood pressure falls below a certain threshold defined by that patient, LV mass, history of hypertension, et cetera, and so we sort of do these dynamic sort of treatment plans while we're there observing directly. And we make a comment, this patient likes a blood pressure greater than X.
Right.
And so we presume everybody understood what we said, and that carries forward. Yeah. Sometimes it doesn't. I love the fact that you're protocolizing that. Let me kind of take this to the next derivative. Sometimes our best intents, sometimes our best efforts are not met. When that occurs, do you follow that up with a sort of a secondary derivative, which is to say now we should get high sensitivity troponins, or now we should get a nephro check. We didn't meet our standards that we set for ourselves based on our intraoperative direct observations, despite our best efforts. Ergo, I fear something bad happened.
Sure. Yeah.
What should we do about it? Have you?
That's great comment. I hope to get to that stage here over the next 6 months. I will tell you where we are now is that the culture has changed to the point where we are talking about what are the targets for this patient. And in those scenarios, as we've all had, where you don't reach those targets, or there is no stability in the intraoperative phase, and you're still transitioning that patient to the ICU, that does happen. We make that known in the communication. We say that these are the targets that we last had in the OR, but we're not happy. We saw still issues with the echo, or we see that there's still potential issues with bleeding. But it's a touch point for people to know that this patient is off sort of the routine. And we're hopeful that maybe we can talk about, as we all start to communicate in that platform, to incorporate those parameters into the decision-making. So now it's not just I'm replacing blood products, or I'm continuing to be concerned about looking at troponins and tracking out or kidney function, but incorporating flow-guided parameters in that. Because before this, those parameters were there, but I don't think it was common culture for us to kind of consider that in each point of when the patient was altering. Sometimes it was, sometimes it wasn't. Protocolization really, I think if I could summarize this, it's really just adding that to the communication on a regular basis, consistently with the patient. Just as you're looking at the vital signs, you're now looking at the cardiac index, you're looking at potentially their stroke volume and seeing what potentially how that helps.
David, how do you bake into your processes a non-echocardiographic centric, if you will, metrics? So, we heard so much about cerebral oximetry, peripheral oximetry, sort of balancing those two to be a window of the kidneys, regional perfusion status, et cetera, et cetera. Have you thought about that? How are you dealing with that?
Yes. I've thought it very much in the research space, very excited about the idea. I will go off on a brief tangent on the idea of somatic oximetry being sort of the holy grail, the canary of the body, of being able to assess some way of splanchnic flow and saturation. That would be a phenomenal tool. We're not there yet, but I think if we had mechanisms of really regularly seeing that, wow, well, very powerful, right? Cerebral oximetry is another tool that potentially can help identify potentially how to use this. I'm also a believer in looking at EEG monitoring and assessing that and incorporating the transitions that are occurring with, process EEG into that algorithm. But I think as these technologies come together and it gets more developed to the point where we actually can use this simplistically and kind of uniformly, it gets very exciting. But now, more and more the technology is really growing. Yeah.
I love just what you were saying, to take it back just a little bit, how this is creating the communication between everyone, because I know I've done hearts too, like you get them and it is a dynamic process, and you roll them out and you're like, oh, this is going to be a mess. And the fact that we know where we want them to be, and we thought we were talking to the surgeon about it, but then the surgeon comes and they say what they want, and it just becomes a big mess. And it's very difficult for the nurse on the floor.
Sure.
The critical care nurse to be taking care of them, the recovery nurse to be taking care of them. And so that aspect of it, how was that getting everyone together? I know you were coming up with the targets was hard, but like the communication aspect of that.
So I actually, the communication has been reinforced when we have a difference opinion on the targets. Let me rephrase that. So, which is great, actually. So when we, the cardiac anesthesia team identifies these targets, it's been a touch point of discussion now. So with the intensivists who take care of the patients 6 hours later, and they are not in agreement with those targets. And it's great because at that point, the discussion very much falls at, okay, well, you identify the targets at this point, and that sort of communication of understanding that the dynamic process is demonstrating itself, and maybe we're both right? Yeah. And now we can talk about that instead of kind of doing the blame game or thinking like that, just really appreciating that dynamic process. But I'll tell you, the cardiac anesthesia group is much more in discussion now with intensivists than we have been, simply because of the fact that this communication tool has been allowed us to kind of have a piece of paper to allow us to say.
I totally get it. I love
fantastic.
It. Another sort of area that I always considered, less elegant in our preponderance to define elegance, the end diastolic area, great metric of preload. And certainly, we all have known and have been taught a better reflector, a preload stretch of the sarcomere at the end diastolic part of the cardiac cycle than traditional hemodynamic pressure measurements. That said, what can you share with us your sense or experience about end diastolic area as a metric of preload to reflect volume status of the entire body?
Yes.
As it would be necessary to know that with respect to perfusion of end organ, vital end organs.
Sure. Well, I mean, that topic, if I can connect to the topic of point-of-care ultrasound, is fundamentally one of the things that got me so passionate about this topic, right? You have tools now that give you the ability to appreciate end diastolic area, giving you a representation of stroke volume to optimize patients' forward flow. And I think, I fundamentally believe that it is in the wheelhouse of all anesthesiologists to get an appreciation of cardiac ultrasound. I will identify it as a separate, complete modality, not echocardiography, not transthoracic, not transesophageal, cardiac ultrasound with the idea of evaluating and appreciating end diastolic area for assessment and the change, right? And to identify an idea of stroke volume. That's actually much more reliable than looking at other parameters like the IVC and things like that. Going down the road of point-of-care ultrasound, it's very interesting to see how I've kind of across different specialties, people get there is sometimes a fear associated with cardiac ultrasound because of its label as being echocardiography, and clinical decision then is made on looking at parameters that perhaps, my opinion, not as solid, looking like things like the vena cava and assessing that as a marker of central venous pressure, but then using that as your determination of preload status. Incorporating the idea of familiarity with the end diastolic area, I think, is something fundamental that anesthesiologists, if we incorporate that into our training, would be a incredibly useful tool.
So take it back, because for those of us that don't do ultrasound, or our listeners that are not really in that space, what is the difference between all of those?
Yeah, so I mean, it's many different ways of looking at it, but if you kind of go with the idea of using ultrasound more similar to your stethoscope, and seeing how now ultrasound can give you, because it's become so portable, more economical, and allowing you to get true insight into the body, which is kind of the premise of point-of-care ultrasound. How do we embrace this technology? Other specialties have been using this for over a decade now, emergency medicine, some areas of critical care, to really assess that patient. Patient's hemodynamically unstable, very much. Is it just an issue with hypovolemia? Is it a cardiac contractility issue, or a low afterload state? Ultrasound can very quickly answer those questions, much better than your stethoscope. And now, since the technology is caught up, how we can learn how to use this parameter in our bedside assessment of patients. And,
so a TE is esophageal.
Correct.
And a TTE is transthoracic.
Yes, transthoracic with certification as it should be, with very rigorous regimen, but the idea, you're changing a diagnostic tool, something that you're ordering as a test to be able to know definitively the patient's pathology, and then you're talking about sort of an assessment evaluation, again, a physical exam tool that you're using in a situation where the patient has an acute event. Somebody is hypotensive. At that point, what tools do you have at the bedside? Your stethoscope, using your bedside evaluation, your standard vital signs. Well, let's add ultrasound there to see if you can help get an assessment.
I'm going to push you, though. I'm going to challenge you.
No, please, yes.
So I agree, and we are on the same page. And preload as a metric of end diastolic filling is assessed by end diastolic area is very elegant and very well correlated. My question is this, and it's one that I've only begun to ask myself in the last few years. Though we measure preload as a surrogate of total volume, body volume, is it doing us a service by saying that is the same? In other words, combining things like pulse pressure variation, stroke parameter variation, or more systemic, if you will, parameters of total body volume, which is relevant if I am interested in what is the volume that would be perfusing my kidney.
To optimize,
Is that necessarily demonstrated by end diastolic area as a reflection of preload. And it's a question I've begun to ask myself. So what do you think?
Yeah, so I will try to answer that in sort of the spectrum of optimizing fluid status. You have your static parameters, right, and then going to dynamic parameters. And the idea of static parameters of being things like the vena cava, less elegant, looking at end diastolic area of the left ventricle as being more elegant to give you a representation of stroke volume. And then you start going into your dynamic parameters of stroke volume variation, pulse pressure variation, VTI variation with ultrasound, whatever variation technology you want to talk about. And then optimizing the patient's forward flow because you've now got them to the top of the Frank-Starling curve versus the static parameters. You're just not making sure that they're at the very end of that Frank-Starling curve, right? And so your level of sophistication and ability to titrate, you should use all of those technologies, right? And I 100% agree that end diastolic area, that's why I meant kind of connected the point of care point of it, is it is good to help identify this patient is hypotensive systemically because they have a low volume status.
Total volume.
Total volume status.
Volume,
that is appropriate for these static markers and parameters like end diastolic area. If you're trying to be sophisticated and optimize flow to say, I don't want that patient to get that deteriorated, I want to actually optimize them on the Frank-Starling curve, then you have to fall into these dynamic parameters and use those. And I think there's many techniques, and it's great to see how that area is rapidly developing, becoming more approachable. More clinicians are using it. So that's my spectrum of how I kind of approach it. But so use one in one scenario, but ideally, if you can, get all the way up to the incorporation of a dynamic parameter.
Beautiful. Shift gears.
Yes.
POCUS.
Yes.
Where are you using it? How are you using it? Are you using it in your preoperative assessment of patients?
Oh, pre-op assessment.
So I can tell you some data from our last year of launching. We've had about a year and a half of launching a point-of-care ultrasound service that's available from 6 in the morning till 3 in the afternoon for any kind of consultation. We did about 1,400 scans in the year and a half. 56% of those were in our pre-op area, where basically, and the number one reason is patient had a medical history, somewhere on the fence about whether they needed formal studies or not, but the primary anesthesia team just wanted to know, hey, could you take a quick look at their heart or their lungs and let me know what they look like today, right? We all know that EF of 30% today of surgery could be 45 or it could be 25 or it could be 10, and getting that quick assessment from a point-of-care ultrasound exam is the number one thing we do.
And what is the data?
So I can talk about our accuracy. And, let me go back and say some of the data that we have in terms of its impact to the primary provider once we do that examination. About 76% of the time, we are able to give information that provider finds useful that alters their management. So potentially putting an A-line, having another drip set up, these are all the markers of potentially value.
Because you found a valvular abnormality, because you found...
Or we just found the same. We confirmed that this person, I think this person has, this person has a history of mild MR. Can you just take a quick look? That's a little bit more sophisticated, but, something like, it's not, but I hear a murmur. Can you take a quick look to make sure that this thing's not just completely wide open, and then we can say yes. Again, point of care hat on. The MR is not severe, and then that sort of reassures the provider. That would be an example. Or aortic stenosis. Looking at that, somebody has a reduced ejection fraction. What is their ejection fraction today? And getting a nice rough assessment. And we never kind of pinpoint. Again, not trying to identify this as transthoracic echocardiography, but just saying the function looks within this range. Moderate function, mild dysfunction. Those kind of quantifiers to it. But when we do those kinds of exams, it alters the management decisions about 76% of the time. 24% of the time, so out of the 1,400 scans, 24% of the time we found actually new diagnoses. So, for example, somebody had, asked us to do the bedside because the patient has a poor functional status of, not ambulating very much. We do exam and we see a decreased contractility, or we see an aortic stenosis, or we scan their lungs and we see large pleural effusions that nobody knew existed. Sometimes we scan someone who swore that they ate 8 hours ago, and then we scan their stomach.
Gastric scanning,
and we see that if you ate 8 hours ago, something's causing you to be stressed because there's still food in your stomach. So there's many different parameters. Again, using the idea of any kind of physical exam you have, you can use ultrasound to potentially improve your assessment.
Excellent.
Yeah, that's great. Well, we do probably have to wrap this up,
sure.
Unfortunately. I mean, we could sit here and talk forever.
I'm sorry, this is an area I get very excited about.
No, you don't apologize. I love it. And we can refer back to what we were talking about, because we did cover a lot of this at the ASA, the TopMedTalk podcast that we did there. And the cardiac stuff we chatted with you before. So hopefully we can reference all that and definitely set up another one of these. Now, I know that you're doing a POCUS meeting.
Yes.
In September. So give us a plug for that.
Oh, well, thank you. September 28th, 29th. If you look at POCUSeducation.com, you can find all the details. It's in Huntington Beach, so POCUS education.com. It's from the Department of Anesthesia at UCLA and Loma Linda. We do this every year, fourth year doing it, and it's totally devoted to point-of-care ultrasound.
Awesome, and it's a day long?
Day and a half.
Day and a half.
Saturday and Sunday, right along the beach.
Keep up the good work.
I know. It's awesome. Thank you so much for everything that you're doing in this space. This is good stuff, and can't wait to hear what comes out of the goal-directed stuff, the hemodynamic management stuff, so keep us abreast of that. Well, I want to make sure that thank you everyone for listening to TopMedTalk. Make sure you join us on social media. We're on Twitter, LinkedIn, and now apparently we're on Instagram, Saul. Do you know what that is? I
read about that.
You have some kids. Be sure to subscribe and check us out on TopMedTalk.com. Cheers.
Great. TopMedTalk.
Nate Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.